Hello everybody. Today we are going to talk about myofunctional appliances part 1. Okay. Learning outcomes for this lecture is at the end of the lecture students should be able to explain the mechanism of action of myofunctional appliances, the principles of myofunctional appliance therapy, able to classify myofunctional appliances, able to explain the design indications, contraindications, and clinical scenario in which various types of myofunctional appliances are used, and also explain the mechanism of action, indications, and contraindications of various orthopedic appliances. What are myofunctional appliances? Myofunctional or functional appliances make use of the facial and masticatory muscles to produce changes in the relationship of teeth and the dental arches. Now, these appliances aim to utilize or eliminate or guide forces arising from muscle function and growth to alter the skeletal and dental relationships. Now, let's have a look at how we can classify these appliances. Now, Tom Graeber came up with a classification which only involved removable appliances. He classified them into three groups on whether they are teeth or tissue supported. So, the group A appliances are entirely supported by the teeth, and while group B are supported both by teeth and tissues, and the group C have both tooth and tissue support, but they are positioned in the vestibule. Now, with the advent of fixed functional appliances, the classification was modified. So now we have removable functional appliances such as the activator, bionator, Frankel, and twin block. We have the fixed appliances which cannot be removed by the patient at will, and uh, they are divided into two groups. One is a rigid fix, example herbs, Mara, and the flexible fixed ones, examples are Eureka and Jasper Jumper. Okay, we also have the semi-fixed or removable fixed appliances. This basically means some components are fixed, cannot be removed by patient, while some are detachable. An example of this is the Denholz appliance or the Bass appliance. Now, tooth-borne passive Profit classified them into four groups, whether they are tooth or tissue borne or passive or active. Now, the tooth-borne passive appliances are also known as myotonic appliances. They depend on muscular activity. There is no active components like springs or screws. And an example of this group is the Anderson activator, bionator, and the herb. Now we have the second group, which is tooth-borne active myofunctional appliances. Now these are myodynamic appliances. They depend on muscular activity, and they are modified with active components like springs and screws. And examples are the elastic open activator, beamless appliance, herbs, modified bionator, stockfish appliance, and the kinator. Now the third group is the tissue-borne passive appliances. These are located in the vestibule with little or no contact with the dentition. An example is the functional regulator or FR of Frankel. Now the last group is the tissue-borne active appliances. These are located also in the vestibule, but they have contact with the dentition. And examples are these are the lip bumpers and oral screen. Now, there's also another classification which is based on force transmission. We have three groups here. The group one transmit the muscle force directly to the teeth. Example are the inclined planes. The group two, they reposition the mandible and the resultant force is transmitted to the teeth. And in this group I included the activators and bionator. Now the group B reposition the mandible and the resultant force is in the vestibule outside the dental arches. These examples are vestibular screen and Frankel's function regulator. Okay, what is the principles of myofunctional therapy? Basically, there are two factors. One is force application. Now, this causes forces acting directly or indirectly on dentition and the basal bones, and it results in primary alteration in function followed by a secondary adaptation in form. Most of myofunctional appliances act on this principle. Now, the second principle is force elimination, meaning it eliminates abnormal and restrictive forces which may be muscular or environmental in nature. It removes the adverse effect on normal function and preserves proper function, and this allows for normal development of the orofacial structures. Now, the forward positioning of the mandible in myofunctional therapy results in the re-education of the musculature. The forward positioning causes muscles to adapt a new functional pattern. To a lateral pterygoid muscle stimulation, there is increased activity of the lateral pterygoid muscle, especially in superior head and the retrodiscal pad. Now, this leads to condylar cartilage growth and subsequently sagittal mandibular growth. Now, third, decreased biochemical feedback. Now, chondroblasts located in the condyle secrete antimitotic substance. Now, myofunctional appliances causes decreased secretion and acceleration of condylar growth. For unloading of the condyle, with myofunctional appliances, the condyle is distracted from the glenoid fossa. Proliferation of cellular elements, remodeling of the glenoid fossa, and resulting in mandibular growth. Now, transduction of viscoelastic force. Now, the elastic force arising from muscle skin is transmitted to the dentition. Now, lastly, differential eruption of teeth. Now, by modifying the myofunctional appliances with molar stops or acrylic guide planes, the eruption pattern of the teeth can be modified. Now, what are the effects of the myofunctional appliances? Now, they have effects on the skeleton and the dentition. In the skeleton, there's a temporary acceleration of mandibular growth with forward positioning of the condyles and remodeling of the glenoid fossa. There is also some restraint of forward growth of the maxilla and also causes an increase in the lower anterior facial height. Now, the effect on the dentition is basically the upper incisors retrocline while the lower incisors procline. The upper buccal teeth tip distally while the lower buccal teeth tip mesially. Now, what are the indications for myofunctional appliances? Now, the various designs are available to treat all kinds of malocclusion. function, but they are mostly effective in class 2 cases, especially where there is a deficiency in the mandible. Okay, let's have a look at the indications of myofunctional appliances. First is age. Now, myofunctional appliances is used in a growing class 2 patient. It is time to include the pubertal growth spurt in the duration of treatment. Now, it produces skeletal changes which diminishes in adulthood. Now, we have to remember that the chronological age does not coincide exactly with the rate of growth, and this causes a difficulty in predicting the timing of the growth spurt. Now, various ways have been used to predict the timing of growth spurts, this including taking standing height measurements and wrist radiographs, cervical vertebrae maturation status, and secondary sex characteristics. Now, second indication is the growth pattern. Now, as far as vertical skeletal growth is concerned, is indicated when the subject has an average or reduced lower anterior facial height. Now, in the AP skeletal pattern, a reduced SNB angle or mandibular deficiency is indicated for myofunctional appliance. Other indications are a severe skeletal discrepancy, reasonably well aligned or uncrowded dental arches, lingually tipped lower incisors, and good cooperation of patient and family. Now, what are the contraindications of myofunctional appliance? Now, class 2 skeletal patterns due to maxillary prognathism or increased SNA angle is contraindicated, as well as an increased lower anterior facial height. Now, proclined or labially tipped lower incisors are also contraindicated, as well as crowding of the arches. Now, myofunctional appliances have their limitations. Now, they are associated with extrusion of the buccal tooth, which can result in an increase in the lower anterior facial height. Now, this may be favorable in some situations, but largely it's unfavorable, especially in high angle cases. Now, with myofunctional appliances, individual tooth movements are not possible, thus the treatment will have to be completed with the second phase of fixed appliance therapy. The success of myofunctional appliances is depend on patient compliance, and the appliances are not effective in a non-growing patient. Now, what are the advantages and disadvantages of myofunctional appliances? Now, the advantages is it can be used in the mixed dentition to utilize the growth potential during the pubertal growth spurt. It eliminates adverse perioral muscle function. There's minimal chair side adjustment. It is easier to maintain oral hygiene since it's removable. No side effects of mechanotherapy, example decalcification. Now, the disadvantages of these appliances are they are ineffective in a non-growing adult subject. They are heavily dependent on patient compliance. They cannot correct dental malrelationship, example crowdings and rotation, and they may need a second phase of fixed appliances to correct dental problems. Now, let's have a look at the bite registration, or also known as a construction bite for the myofunctional appliances. Now, this bite registration is basically an intermaxillary dental wax that records the predetermined relation of maxilla and mandible in all three planes of space. Now, the purpose of doing this bite registration is so that we can advance or set back the mandible and to block the bite so that the lower incisors intrude and stop eruption, and the buccal teeth is selectively guided into eruption. Okay, principles of bite registration. Now, in the early mixed dentition, the mandible is advanced not more than 4 to 5 millimeters, while in the late mixed dentition, the mandible is advanced not more than 6 to 8 millimeters. Now, concerning the midlines, the upper and lower midline should coincide. Now, if there's a skeletal midline deviation, this is corrected with the bite registration, while the dental midline deviation should not be corrected. Now, bite registration follows the rule of tens. This simply means that sum of the vertical opening plus the anteroposterior advancement should not exceed 10 millimeters. Now, for example, if the vertical opening is 2 millimeters, then the maximum anteroposterior movement is 8 millimeters. Now, in the situation of very large overjets, it the advancement of the mandible is done in phases in a stepwise manner. Now, concerning freeway space, the vertical opening must be at least 2 millimeters more than the freeway space. Okay, now sometimes a low construction bite is used together with a high forward advancement of the mandible, and this is usually done in severely retruded mandible in class 2 Dept situations. Now, you may also do a very high construction bite with little forward advancement of the mandible. Now, this is usually utilized in class 2 Dept patients with a vertical growth pattern. Now, a purely vertical construction bite whereby the bite is open up to 5 to 6 millimeters with no mandibular advancement. Now, this is used in cases of deep bite or open bite. Now, a reverse construction bite is done when in class 3 cases whereby the bite is open and the mandible is set back. Now, orthopedic appliances. Now, when we talk about forces used in orthodontics, there is two types of forces. One is the orthodontic force and one is the orthopedic force. Now, the orthodontic forces are light forces in the region of 50 to 100 grams, which moves teeth and is applied by springs or active wire components. Now, the orthopedic forces are heavy forces in the region of 400 grams, and this effect affects the skeletal tissue although they are applied through the teeth. Now, what is the basis of orthopedic appliances? The amount of force utilized are heavy forces over 400 grams. Now, teeth movement does not occur due to hyalinization. Forces conducted to skeletal tissue produce the orthopedic effect. A duration of force. Now, the duration of force are intermittent forces ranging from 12 to 14 hours. Now, minimum tooth movement but maximum skeletal effect. Now, what are the types of orthopedic appliances available? The three commonly used ones are the headgear, face mask and sheet cup. Let's take a look at each of it in a little bit more detail. Now, headgears, these are one of the most commonly used orthopedic appliances. They basically intercept maxillary growth and may distalize maxilla or the maxillary dentition. Now, components of headgears. Now, the face bow, it consists of a face bow, consists of the force element, which is the elastic strap, and it consists of a head cap or cervical strap. Now, the face bow two types. One is the inner outer bow type, and the other is the J hook type. Now, the inner outer type face bow transmits the extraoral forces of posterior teeth. Now, it has three components: an outer bow, an inner bow, and a junction. Now, the outer bow is made of 1.5 millimeter round wire. Now, the outer bow of the consists of three types: short, medium, and long. The short means that the outer bow is shorter than the inner bow. Medium means they are both of the same length. The long outer bow means it is longer than the inner bow. Now, the inner bow is made from 1.25 millimeter round stainless steel wire. It is inserted into the buccal tubes on the first permanent molars, upper first permanent molars, and it consists of a safety locking mechanism. Now, the junction of the inner and outer bow can be asymmetrically positioned to correct asymmetries as shown in the diagram. Now, the J hook type of face bow fits on stops placed on the anterior segment of a maxillary arch wire. Thus, it's used with upper fixed appliances, and the orthopedic effect is limited. Force element. The force element is the active component which provides the force. It may be some form of springs, elastics, or stretchable materials, and it connects the face bow to the head cap or the neck strap. Now, head cap or cervical strap. Now, this provides the anchorage for the appliance. It's anchored either on the rigid skull bones or in the neck, or it may be a combination. Now, what are the principles of headgear use? Now, the center of resistance of the dentition and the center of resistance of the maxilla in relation to the application of force determines whether the movement is a rotation or translation. Now, point of origin of the force. Now, vertical versus distal direction of force determines the type of movement that is obtained. Now, point of attachment, we can vary the force direction by varying the length of the outer bow or the angle of the outer bow. Okay, this is an example whereby the length of the bow alters the force direction, and if the force does not pass through the center of resistance, then you get tipping movements instead of translatory movement. Now, the few types of headgears. One is the cervical headgear, which is a low pull headgear. Then we have a occipital or high pull headgear. Now, you can have a combination of the cervical and occipital headgear, and then we have the vertical parietal headgear, and we also have the asymmetric headgear. Now, The second appliance we look at is the face mask. Now this provides anterior protractory force. It's anchored on the chin or forehead or both. Now it is used in a growing subject with a retrusive maxilla, that is a low SNE angle. Now if it's anchored on the chin, then the appliance will be able to restrict mandibular growth. Now, chin cup restricts the forward and downward growth of the mandible. There are two types: the occipital pull, which is used in mild to moderate mandibular prognathism cases. Now, the vertical pull is used in high angle cases or increased low, lower anterior facial height. Okay, these are the references for today's lecture.